You are tuned into the Dr. Tina Show with Dr. Tina Moore. For more, visit drtina.com. On this episode of the Dr. Tina Show, we are deep diving into the conversation around the latest study that just came out linking vision loss to Ozempic. My inbox has been flooded the past week. Everybody saying, can you talk more about this? I want to hear your take. I want to know what you think. I've also gotten a ton of hate mail from people saying, see, Dr. Tina, Ozempic causes blindness. So we're going to break it down. And to do so, I've invited my dear friend and naturopathic cardiologist, Dr. Lauren Latanza. She is a Scottsdale, Arizona doctor. She's been in practice a good long while. She specializes in the cardiovascular system. She is my go-to expert for all things vasculature. And since this paper came out titled The Risk of Non-Arteritic Anterior Ischemic Optic Neuropathy in Patients Prescribed Semaglutide, that's a mouthful. Hopefully I pronounced everything right. I'm a little tongue-tied today. Got the paper, took notes all over it, and we're doing a deep dive into the physiology of what's happening. I think you're going to be surprised. You're going to learn something, and if you're a hater, you're definitely going to learn something because, as always, we got to go back to the basics on how the body works, how type 2 diabetes is handled in the body, how obesity is handled in the body. This is a nuanced conversation, so let's jump in. Dr. Lauren Latanza, thank you so much for coming on the Dr. Tina Show today. We are longtime friends and you've been on the show before, so we've brought you back in for a very special episode. So thanks for being here.
I am so glad to be here. Absolutely. My pleasure.
Yes. Well, okay. This whole eye stroke, vision loss, blindness around Ozempic conversation, right? This has been all over everywhere for the past week or so because a study came out recently and everybody's dropping into my inbox and it causes blindness, Dr. Tina. You need to address this. So I went in and was reading the study and then I called you and I was like, hey, lady, you are my naturopathic cardiology expert and let's talk physiology here. And you and I both agreed that they're missing some things in this study that they're not telling us, they didn't look at, they're not explaining well. And so that's what this episode is all about today. So I'm really excited to dig into this.
Absolutely. I think it was, kind of an important piece of it. The study was not ultimately surprising. Like I mentioned to you, it's not a large piece of, not a very large population that's going to develop this. The 8.6%, 8.9% increased risk. But ultimately, it's not surprising because we know the physiology. The hemodynamics of these patients that have compromised endothelial function after years of poor metabolic health and hyperinsulinemia, we know that they're going to have, again, compromised vascular health. And so when they have this tank in their blood sugar upon use of Ozempic or other GLP-1 agonists, they're going to have a tank in their blood sugar and it's going to have residual effects on that compromised vascular system.
Yes.
Especially in the retina.
Yes, which is such a sensitive region. So let's take this bit by bit and explain to people what's happening. So this study came out. It was this very rare type of eye stroke. This was a retrospective matched cohort study that was just published in JAMA Ophthalmology, and it's titled Risk of Non-Arteritic Anterior Ischemic Optic Neuropathy in Patients Prescribed Semaglutide. That is a mouthful. They looked at a data registry of patients that were evaluated by neuro-ophthalmologists at an institute from 2017 through 2023. And what they found was when you crunch the numbers on a retrospective Cox study, that it looks pretty scary. We got some pretty scary numbers. And so people are running around the internet screaming that Ozempic causes blindness. But let's back up. So I've got the study here and I can share it in the show notes for everybody so they know. It's got lots of notations here. What is happening to the retina in a patient and to the cardiovascular system at large in a patient with compromised metabolic health?
Well, so I always tell patients, your ophthalmologist may be the first person to identify hypertension or high blood sugar because of the microvasculature that infiltrates and feeds the retina. So you've got these tiny little blood vessels that are really at the will of, be it high blood pressure with the shear forces, high blood sugar being affected by the hyperinsulinemia, the advanced glycation end products, the high amounts of reactive oxygen species. So they're really being highly damaged, and they're just so fine. And the endothelial lining, which you know I'm big on, the endothelial lining, again, just one cell layer thick, they're being so damaged, and it's really hard for them to regenerate in this inflamed environment. So they're being damaged from the inside, and they're not properly responding to the adequate hemodynamics. They're not expanding and dilating, feeding the retina, feeding that optic nerve. So we see that there's a shrinking in the vessels, a dysfunction in those vessels. And so the retina is not receiving adequate blood flow, adequate nutrient levels. So that's just from go. So we know that there's problem with those teeny tiny little blood vessels. As that progresses over the years, then it gets worse and worse with the blood vessels as well. Then say we come in with something like a GLP-1 agonist, and we say, all right, we're putting up a halt. We're slamming the brakes on the elevated insulin, slamming the brakes on the elevated blood sugar, and we're just tanking that, which is good. We have significant cardiovascular benefits, significant benefits on, I mean, we could go on and on. The inflammation in the system, the neuroinflammation. So we know that bringing those numbers down is beneficial across the board to the entire system. But what happens to the blood vessels and to the surrounding nerves? They suddenly are kind of starved because they're used to being constantly bathed in sugar and insulin. And so you're changing the environment so that they kind of go into a shock. So they kind of shrink up. So these ischemic changes are really not surprising at all. Granted, this was not at a very high rate. So again, I think 8.9% was the ultimate findings of these diabetic patients.
Yeah, the numbers we'll get into that. I want to back up a little bit though. I don't mean to interrupt your thought process. I just want to back up. I want to make sure that everybody understands this in like normal people terms. So first off, what is the endothelial lining? Describe that.
So the endothelial lining is just the innermost wall of the inside of a blood vessel. So it's what interplays with the blood flow. So it's very sensitive, and it's got all of these nice fibers and sugars, or proteins and sugars that interact with the blood and produce nitric oxide, which is allowing the blood vessel to expand, bringing the blood pressure down, or constrict, bringing the blood pressure up, depending on what's appropriate. So that inside wall of the blood vessel is what's often compromised and kind of at the core of coronary artery disease, peripheral artery disease. So we have to really be concerned about that endothelial lining as kind of our barrier system for the vascular system.
And it's very reactive in real time. It's very sensitive to what's happening. And like you said, it interplays with how the vessel behaves, whether it dilates or constricts. Now, secondarily, I'll add, when you have hyperglycemia or elevated blood sugars for an extended period of time, then you're also going to get thickening of the vascular walls. You're not just going to get disruption of the endothelial layer, but the actual additional lining walls of vessels get thickened and fibrotic. So they're not as responsive either. So that's okay. Step one, I want people to understand this. And then the second part is, let's go back to the retina. You were talking about microvasculature. Explain what that is. Like, explain the artery into the arterioles, into the capillaries, into the microvasculature. I can't talk today.
Yeah. So the big
microvasculature.
So the big picture of the arterial system. So you have your heart, and then out of that, the arteries are what brings blood away from the heart to deliver nutrients and oxygen. Starts with the aorta, and then it branches off, and then it goes into smaller branches, and then the arterioles, and then in these fine capillary beds is kind of that in space where it says, all right, are we delivering? And then it turns into the pickup to take back to the heart. So it gets very, very fine, and it's literally one red blood cell at a time making its way through.
Yes.
So that is a direct interplay of what's going on in the bloodstream and how that's interacting with the endothelium.
Okay. So in the type 2 diabetic, or in someone who's had extensively high blood sugars for a long period of time, that entire system that you just described loses its elasticity. It gets more fibrotic, like I just said, and that endothelial lining, that beautiful dance of what you call the glycocalyx and all of that jazz in there gets really fouled up because of this chronic, longstanding high blood sugars leading to high inflammation. Is that the gist of it? I mean, would you say that explains it decently?
And
what do you want to add to that?
Well, when I talk to patients about, so if we can kind of look at the hemoglobin A1C, HbA1c, which is something that will come up when we're talking more about this study. But if we think about the red blood cell, the hemoglobin A1c is an assessment of how sugar-coated is that red blood cell. So I tell patients, okay, if we're thinking about your red blood cell is like a Cheerio, for example, is it a sugar-coated frosted Cheerio? You can imagine that rolling through that teeny tiny little hallway. That's going to cause more damage, more nicks, more irritation than a not sugar-coated Cheerio. So I think that that's a good way to kind of picture it too.
Okay, yeah. These sugars dance together. They communicate together. So a sugared up red blood cell, i.e. one, patient with an elevated hemoglobin A1c is going to be a much less smooth and elegant flow. And then additionally, again, the vessels themselves have lost elasticity. I mean, quite literally, when you look at what diabetes does to just your fibroblasts and your elastins in all of your cells, it makes everything fibrotic and tight. And interestingly, GLP-1s reverse that and change that entire picture and improves elasticity across the board in the body. That's one of the reasons why folks on GLP-1s say, I'm moving better, I feel better. It's because it's actually returning this elasticity to our tissue. So not to digress. All right, so the retina, and I say the same thing to patients, your ophthalmologist or somebody looking in your eyeballs is going to diagnose your type 2 diabetes probably before someone else does.
Go see a cardiologist, right?
Because they're seeing these retinal changes. And when folks hear me say this, I'm sure people who've listened to me for a while have heard me say this a million times. I always say type 2 diabetes is really the end result of a disaster that's been going on for a decade or two. And what I mean by that is if those retinal changes are happening and they're visible, they're happening in the kidneys. They're happening everywhere else. There's a fine vascular bed where these really important interactions are happening at these end organs. And so that's exactly what I mean when I say you're looking at a life of dialysis at the end of this trail, because you're your blindness and dialysis, if you get that far, if the cardiovascular disease doesn't take you out first. And then if you keep going, you're going to end up with dementia, because guess where another huge vascular bed is? The brain. So I'm just trying to lay the physiologic groundwork for people to understand this. Okay, so before we jump into the study, I've been getting asked inside of my program, my Ozempic Done Right University, some of my students in there have asked, well, hey, I'm finding, because I provide them with like a 27 and growing page document where every study I find, I throw in there for them, for the students in my program. And one lady was going through looking at the eye studies, and she said, it looks like GLP-1s are worsening diabetic retinopathy. And I was like, yes. And here's my hypothesis, and I'll have you add on to what you were, because you were going there when I interrupted you. If you are bathing a tissue in high levels of blood glucose, it becomes accustomed cellularly and receptor-wise to those high levels of blood sugar. And if you've got someone who's a long-standing diabetic, is it safe to say they probably got pretty severe retinal damage, right? And probably pretty severe cardiovascular damage.
Certainly.
Okay, so you put them into a state where even if it's not hypoglycemia, you just significantly reduce that blood sugar load quickly with the GLP-1s, because they don't actually induce as much of a hypoglycemia, say like metformin, but they will definitely pull it down into normal levels and maybe below normal, maybe a little bit more with tirzepatide. So now those tissues are quite literally starving for a hot second. So they're going to respond by doing some pretty funky things. And nervous tissue is quite sensitive, and that microvasculature is too. So I'll let you take it from there, because that's where you were going when I cut you off.
Yes. So it's that relative hypoglycemia, right? So even if it's not textbook, under 60, 65 level of blood sugar, it could be your normal was your fasting blood sugar around 160, 170 or higher. And then suddenly you're having your fasting blood sugar 80 or 70, something that is a target, but ultimately it's low for them. So that is meaning that we're basically starving those cells from what they're used to. You know, if we take you and you're used to eating a 2,000 calorie a day diet and suddenly we're giving you 500 calories, you're gonna feel it.
My tissues are gonna freak out for a second.
Exactly. So we get this
narrowing.
Oh no, I was just gonna say, so we do get this narrowing because they're not being flooded with that level of sugar and insulin like they're used to.
Well, sometimes these folks have blood sugars of like 300 and something.
Yes.
And they're swimming in insulin, which is pro-grow. Insulin is an anabolic hormone, essentially. It's a signaling peptide hormone. So they're swimming in this soup of it's a mess. I don't have a better word, but it's just a disaster. And people are walking around like this every day, not realizing what's going on. And all of that insulin is causing this fibrosis as well. So now, explain in detail what's happening when you say there's vascular spasm. What is that and why?
Well, so it starts with the patient being hyperinsulinemic. So they've got massive amounts of insulin swimming around in their bloodstream all the time. That alone constricts the blood vessel because it cuts off the ability for the blood vessel to produce nitric oxide, which again allows the blood vessel to expand and dilate, flooding the tissue, flooding the nerve, flooding the retina with blood. Now, when we cut that, which is again an already compromised vascular system, so we have this blood vessel that's not able to relax and expand, and then we starve it. So it's just kind of freaking out. So it's going to go into this constrictive mode and it's going to starve the end tissue.
Yes. And this is what I was telling the folks inside my program on my thoughts and hypothesis around this potential worsening of diabetic retinopathy. There's little data on it, but what is out there, and this isn't the study that just came up, this is just general diabetic retinopathy. What little data there is, these folks were extremely brittle diabetics. They were long-standing. So there was a lot of damage done is what I'm trying to get at. There was already a lot of damage done for several decades. And then they were probably put on rockin' high levels of GLP-1s and brought up too high, too fast. So the tissues really didn't have time to recalibrate and to become accustomed to this new insulin, blood glucose level that's happening inside the body on these high levels of GLP-1. So it takes me back to my theory that a lot of this is a dosing and management issue. So that brings us to the study, which is that this other form of eye stroke, if you will, and I think that it's the same thing. I think it's what we're describing here. I think these folks, we don't have anything good in this study to tell us how overweight were these people, how long were they diabetic, how severe was their diabetes, what dose of semaglutide were they on. We don't have any of that data in here. They have conveniently left all of that out because they're looking literally at, it's correlative, it's not causative, it's an association. They even say it in the study, and I'll read the exact quote later, but they're pretty much saying like, this is just an association. We need a lot more data. We need a lot more studies to confirm this, but it's a flag, it's a signal. We should keep our eyes open. But I think this is all a physiologic response. That's my hypothesis on this.
I agree. And there was a piece in the discussion, and I'll try to find the exact quote, but it was mentioning that it was a temporal adverse event, meaning that it was dependent on the time that they've been on this. So the earlier onset was when the rate of the risk was the highest. So That's when we notice that significant change in the blood sugar, the change in the A1C, the change in the insulin. All of these things are dropping rapidly at the onset of use of the GLP-1. And so that's when the risk is going to be the highest, which again correlates exactly to the physiology we're describing.
Yes, exactly. So to put that in simpler terms, basically what she's saying is these folks were having this terrible eye stroke early on in their treatment with semaglutide. It was happening in those early weeks. And again, we don't know the dose. We don't know how compromised were they going in. And this is something I keep saying to the folks who are like, it causes pancreatitis, it causes gastroparesis, it causes all these things. Those are already high risk in the population that is taking these. And if they're dosed too high, too fast, we're sending them over the edge of a pathology that's already happening. They're already on their way. I'd like to know what these folks' retinal health was going into semaglutide. We don't have that information either.
No.
And the other interesting part is there's actually no ICD-10 code for this specific NAION condition. There's only for ischemic eye disease, which is ischemia. Explain what ischemia is and why that's so bad to the blood vessels.
Ischemia is when you just cut off the blood flow to the region. So it's no longer receiving nutrients, it's no longer receiving oxygen. So that piece of tissue that's being flooded or being fed by that vessel is going to go kaput.
Yes. So basically, we're having a adverse physiologic rebound event.
Mm-hmm.
That's what I think it is.
Mm-hmm.
Yeah.
I would agree.
And that's when yesterday I got you on the horn and I was like, this is what I think is happening. Can you shed some light on this? And you agreed. I was going to do this podcast solo. And I was like, I'd much rather have Dr. Latanza on here because she's the cardiovascular expert.
Well, yeah, I'm certainly not the GLP-1 that you are. So I don't know all of the details of it, but I'm like, well, it just makes perfect sense. It's just sudden low blood sugar, sudden low insulin. So we've got endothelial dysfunction. We've got vasoconstriction, which the narrowing of the artery. We've got increased inflammation and oxidative stress just because of a relative low blood sugar suddenly.
Yes.
So it makes perfect sense.
Yes.
And increased platelet activation.
Oh, yeah. So talk about that. How's that happening?
So in patients, so again, we set the stage with years of diabetes. So we set the stage with high blood sugar, high insulin for many years, uncontrolled. And so that alone is creating high oxidative stress and inflammation within the blood vessel. Then we take this already inflamed situation and then we tank the blood sugar, which creates a further problem. But the end product is good. The short term is more inflammation, more oxidative stress, and vasoconstriction. So it's compounding the bad vascular system by a kind of shock to the system, just cutting off ischemia to the retina or whatever the tissue is.
And then the platelets being hyperactivated.
Yes, so the platelets being hyperactivated, they just get more sticky. So they're going to be easier to form a clot. So if you're going to have a teeny tiny little clot, you're going to really realize that in those small vascular systems at the end organ. So a teeny tiny little stroke in the eye.
Yes. So it's not the peptide causing the stroke potential. We're just hypothesizing, guys. We're just looking at it's kind of a crappy study, to be honest with you. I've heard people say it's a good study. I'm like, I don't know. It's not. There's a whole lot of information missing here that I would really like to know before I made any decisions. But
I agree.
Based on what we know of physiology, that what we're describing is potentially what's happening here. That's what I thought was happening in these cases of diabetic retinopathy. And we've had those studies coming out for a couple of years now. Too high, too fast, dosing and management issue. Taking a brittle diabetic who is a hot mess of inflammation already with fibrotic vessels that are not happily constricting or dilating as they need to. They're kind of in a pro-constriction mode. And we are basically, it's like throwing a match into a fire. Mm-hmm. You'd think reversing the high insulin, the high blood sugar would be a great thing, like you said, but it cannot happen that fast. You can't take someone who's been 10, 20 years into a mess and then quickly reverse it and hope for good things to happen. The tissues will freak out in a nutshell.
Exactly. You can't just turn off the light and cross your fingers and hope for good. I think it really, and again, this is my hypothesis that I believe we shared, that I truly feel that it is dose dependent. And so if you go more gradual, you will not shock the system like I believe is happening here.
Slow and low. Mm-hmm. So what are your thoughts on the fact that in this study, it was actually almost twice as high of a risk for those who were obese and not diabetic? What do you make of that?
So I have a couple of considerations that I was thinking of. Are these diabetic patients, were they already managed with other medications? So there's that, because I feel that obese patients are largely subclinical hyperinsulinemia, so that they already are insulin resistant, and they're just not being treated because they don't meet diagnostic criteria to be administered a medication.
Exactly. I mean,
so I think that it's still one and the same.
You can't go long periods of time in an obesogenic state and not develop type 2 diabetes eventually. Like eventually the wheels fall off the car. Mm-hmm. Yeah. Would you agree?
Oh, absolutely. Absolutely. I see the same vascular. So I always look at vascular inflammatory markers. So we're looking at how is the health of the endothelium? Is it protecting what's inside those other 3 layers of the artery? are they being infiltrated? And I see that in my obese patients that don't meet the clinical diagnostics for diabetes, they still have the vascular issues that a diabetic does, and they still have insulin resistance that's not, I mean, they're still in a reference range, which is a lousy reference range. So they're certainly not optimal. So in my opinion, it's just, I don't even say pre-diabetes. They're insulin resistant, and that's that.
Yes. Which in and of itself is probably worse than the blood sugar being high. Mm-hmm. Having that high level of insulin all the time is not
a growth factor. Mm-hmm.
It's really devastating on the cardiovascular system. Yeah, it's a growth factor. It's like Miracle-Gro, but it's pro-grow cancer, it's pro-grow disease, it's pro-grow fibrosis, and all of that's happening, and it's pro-inflammation. So your poor cardiovascular system is just like, what the hell, guys?
What I tell patients all the time, because they're like, oh, well, I'm in the reference range. I'm like, no, we're not going to. The reference range is up to 25 of fasting insulin.
Yes, that's right. That's a good point. It's
bananas.
Crazy.
And
yeah, what's your range?
Under 5.
Yeah, exactly. Under 5, guys. Fasting serum insulin should be at 5 or under. 5 is like the red flag.
Oh, totally. If you can't get your fasting insulin 5 or under, if your insulin is not dropping to that, you're not getting that good cellular cleanup. You're not getting that regeneration. You're not getting rid of old senescent cells, because everything is constantly deposit. There's very little, if any, cellular turnover. You're not dipping into your own energy store, so you're never going to lose any weight. So it's definitely something that needs to be addressed, and really tough on the cardiovascular system.
And we should talk about obesity and just adipose tissue in general. Adipose tissue is very pro-inflammatory. It secretes, it's literally a cytokine factory. So it's a little depot. It's like wearing a blanket around of inflammation. And it varies from person to person. And so I'm someone who gains a little bit of weight, my pain skyrockets. It has less to do with the mechanical load and more to do with just that pro-inflammatory nature of my fat. I come from a family where we gain weight and we hurt. And it's just, and I know other people who can gain a lot of weight and they feel just fine. So I think the nature of fat is different for each person. And who knows, that's probably environmental and genetic and epigenetic. And there's different factors that we haven't even probably looked at. But there is the mechanical aspect of it, which is there's pressure on your vessels when fat starts surrounding them. I mean, you get fatty infiltrate basically everywhere, right? I mean, it's not as clear cut as people want to be like, oh, it stays in your subcutaneous or it ends up in your viscera. I'm like, no, it infiltrates all the muscular layers, and that's what your vessels are, is layers of muscular. Right. So that actually dissolves pretty quickly on GLP-1s, that fatty infiltration and marbling all over the body. I think that's one of the reasons we see those big drops in lean mass loss on the studies. They say, oh, they're losing all the muscle. They're just studying lean mass loss. That's being taken into account, I believe, as part of, or it's not being. They're not considering
No, it's
fatty
being
liver.
Infiltrated, but it's not being taken into account.
So if they're losing this fat quickly, but just wondering, and I know you're not an ophthalmologist, but just what you know of the vasculature, I feel like that kind of pressure that it would be imparting, that marbling, and then it's suddenly gone or reduced quickly, would that potentially induce some vasospasm or kind of disrupt a system that's trying to stay stable in this pathologic state?
Yes. Well, yeah. I mean, it's the amount of that cytokine release and then the reactive oxygen species that accompanies that. So you just get this oxidative damage rapidly, and it's tough for your body to keep up with it when you're kind of in this inflamed state.
Oh, yeah. I didn't even think about that. When you burn fat, you are releasing its contents, and its contents are, that's the other thing your fat is a little toxin depot. Mm-hmm. Yeah. So this is why people who have rapid weight loss oftentimes will feel very sick and can have a Herxheimer reaction, which I think is part of the GLP-1 misery that some people report is I think their gut microbiome is shifting and they're probably having a Herxheimer reaction from endotoxins being released. And I think and exotoxins from the gut microbiome. And I think that having that fast weight loss can be, you basically are just you're just swimming in your toxins. They all get released.
It's a massive detox, which provoked detox, which I believe this is what's going on when we have rapid weight loss, provoked detox feels kind of lousy. And so that can certainly be a side effect.
And what does that do to your vascular system?
Well, again, it's this massive release of whatever's been stored up in these adipose cells, and that can be chemicals, metals, I mean, it can be anything. And so it's a sudden release of that. And however that interplays with your vascular system is typically not for the better. So again, a massive amount of oxidative stress and therefore oxidative damage. So you're kind of producing a lot of, it's like rust. It's more corrosive, more damaging to this really fine layer of cells. So it's just really tough for the body to balance that out with antioxidants in this pro-inflammatory state.
Yes. This is all good information. I hope people are listening and understanding what we're saying here, because again, that takes me back to this word of rebound. You said it yesterday. You're like, I think this is just a rebound impact. And I was like, yup, I agree. I want to just share some information about the SELECT trial. If people haven't been keeping up, that was it was sponsored by Novo Nordisk, and it was the big cardiovascular GLP-1, semaglutide particularly. End of 2023, it was released, and everybody was raving about how the reduced risk of adverse cardiovascular events, reduction of 20%. And these were obese, middle-aged people. And again, I don't think you can be obese and middle-aged and not be swimming in insulin, but I digress because their normal range is crazy high, like we just shared. So these people are not clinically diagnosed with type 2 diabetes. And so they're like, oh, well, they're just healthy obese. I don't know if we can have that in middle age. I think the wheels start falling off the car by then. But anyway, 20% reduction, death from cardiovascular, non-fatal MI, which is heart attack and non-fatal strokes, decrease in death in any cause compared to placebo. They were not sure if this was due to the weight loss. And a lot of the critics were like, well, of course, if you lose weight, you're going to have an improvement in cardiovascular impact. But recent data has shown that these results were indeed independent of weight loss, meaning whether they lost weight or not, they still had these cardiovascular benefits. Some other highlights that were interesting from that study is that the semaglutide group had fewer infections. Neoplasms or cancers were about the same. Pancreatitis was less in the semaglutide group. I'm going to repeat that, guys. Pancreatitis was less than the control group. That was less in the semaglutide group. Gastrointestinal disorders were only very slightly higher in the semaglutide group. Slightly higher gallbladder issues, but not significant. Less COVID, less kidney failure, and less pancreatitis. And I don't know if you saw the study that came out just, I think it was this week. Reduction, well, in compared to those on insulin, which we just got through saying is very pro-grow, folks on type 2 diabetics on semaglutide had a pretty marked reduction in 13 different types of obesity-driven cancers. So I think we're going to see more coming out on that. Like, this is a pretty protective peptide. And like I said earlier, it actually improves the elasticity of our tissues and our cardiovascular system. They've actually specifically looked at the cardiovascular system and elasticity with GLP-1. So I don't know, but I think that this blindness, this stroke phenomenon, the peptide is not inducing your eye to like dissolve and stop working.
No.
You're getting an eye stroke because you're having a vascular event, which we just explained from a physiologic standpoint.
The stage has been set, and I may be overstepping here, but I really would argue that all of those, the gallbladder dysfunction, the gastrointestinal issues, cardiovascular issues, anything that does have a higher risk, even if it's marginal, if you set the stage and lay a solid foundation and do a slow dose, you're going to set the stage for decreased instances of all of those, because you can prime your gallbladder, you can prime your organs of elimination to have less inflammation and less damage going into this sudden glycemic change.
Yes, that is exactly why I have my program. That is exactly why I have Ozempic Done Right University. That's what I'm trying to teach in there. So it's a program for clinicians, and I'm letting the public in. But the public, there are some folks in the public saying, well, I don't need to know the doctor version. I'm like, actually, yes, you do. Like, because not every doctor knows what you and I know. And not every doctor is going to be that detail oriented. So we have to really get people optimized as we're increasing the dose slow and low. But there's all these other things that need to be happening so that you have optimal results. It's not just slam someone with semaglutide or tirzepatide as a monotherapy and hope for the best. That is a disaster for all the reasons you just shared.
Well, yeah. And again, kind of setting the stage, talking to somebody and doing the work in what am I going to be eating? Like, am I eating the right things? Am I doing the right activity? Am cleaning everything up so you're not treating a fish in a dirty tank. You're cleaning the tank and then you bring in the GLP-1 to treat the fish and speed up the healing.
Yes. And the GLP-1 is so anti-inflammatory that I'm keen to bring it on early, but this is where low dose and microdose comes in because we got to go slow and low with these people, especially the more compromised someone is, actually, the more careful I am. It's funny. It's like the allopathic community is like, oh, those are the people we want to get to the highest dose the fastest. And I'm like, whoa, that is the group that needs a lot more hand holding. Because
what are they going to be detoxing out of those adipose cells?
Exactly. I do want to hit on the limitations of this study really quick, just so we can make sure the audience hears it. The patients were seen at a hospital that specializes in ophthalmology and has a specialized neuro-ophthalmology service, so the results may not fully apply to other settings. The results are driven by a relatively small number of these NAION cases in the patients exposed to semaglutide. The study does not establish that semaglutide directly causes NAION, the researchers noted. This is directly from the paper. The best approaches to confirm, refute, or refine our findings would be to conduct a much larger retrospective multi-center population-based cohort study, a prospective randomized clinical study, or a post-market analysis of all GLP-1 drugs, they wrote. This was association. They actually used that word in their paper. This is association only. So for everyone running around screaming Ozempic causes blindness, hopefully you just learned something. That's my piece. Okay. Anything else that we should make sure that the audience leaves with? Is there anything you want to add that I haven't poked at you about?
I don't think so. I think we covered a good basis of it.
Okay. All right. So your firm belief, like mine, is that there's a lot more going on than just throwing a peptide at a person and hoping for the best.
Absolutely. And starting low and slow and starting with proper diet and lifestyle changes and building both the dose and your lifestyle and your diet up at the same time will yield much greater benefits in results than just the drug alone. And that goes for anything.
Amen. And the data supporting that, they're actually starting to look at and report on those who are exercising using HRT. And again, some of these are small studies. Some of these are just groups that have a lot of clinical data from their own clinics, and they're sharing it out at different obesity conferences. But the conversation's starting to get out that slow and low and really optimizing lifestyle. It wasn't any particular type of exercise. It was just folks getting exercise, period. Tapering off slowly, again, for the reasons we just talked about. You don't want to slam somebody and you don't want to just drop somebody and throw them back into hyperglycemia, right? So all of these things lead to better outcomes, and folks are actually getting off the peptide and able to stay off the peptide and still continue to maintain that weight loss or even continue to lose weight. So some of this is coming out of Europe right now, but that's what I keep up with this pretty intimately, and that's what we're hearing is like the medical community at large is starting to get this, that yes, these are really phenomenal peptides, and there is a better way to do it than just cranking the dose up to 2.4, hoping for the best. Patients' insurance runs out, they drop the peptide and they go slamming back into a more obese state with now less muscle mass and, a disaster, it sounds like, to their cardiovascular system.
Right. I just think with anything that continues to emerge, we always want to keep in the back of our mind the basis of physiology, the things that we already know. If a diabetic or an obese patient starts activity if they start walking 30 minutes a day, that 0 to 30 minutes is where we get the most significant changes. So 0 to anything is going to yield great benefit. So just start a little bit of the medication, a little bit of the diet and lifestyle, and kind of creep up and crank it up to get those low and slow, but to get benefit on both sides.
Yeah, because health is a journey, not a destination. And we're not trying to do anything fast here. Americans especially want some kind of quick, solid black or white answer to things, and it just doesn't exist. And that's what I try to tell folks when they're like demanding online, like, what's the dose, Dr. Tina? When you talk about microdosing, I'm like, microdosing is reserved for metabolically healthy people or people who are already somewhat metabolically optimized or have done all of this work. They're not toxic soups, where it's not going to work great on those folks. We might get a little bit of benefit, but we're not going to see the full impact. So there's a lot of other work to be done. And then number two, as you just so beautifully described, like it depends, right? Like it depends on the person sitting in front of you. And that is a much larger clinical discussion. That's what I go into inside my program, is like, what does that mean when we say that? Because it's individualized. Every person sitting in front of us is an individual, not a pathology. So we have to address what they need.
Well, yeah. And I think that you want to find somebody that you will work with so that you are kind of being held accountable. And it's not just, here's this med, keep doing what you're doing that's already not working for you. So if you work with somebody who's, walking you through the diet and lifestyle changes as well, and saying, all right, let's get you on the proper dose for you, rather than just blanket, send you off into the wilderness, you're going to yield better benefits that are more specific. I mean, and they're more sustainable.
Right. Oh, of course. Exactly. I mean, you're changing physiology. That's what we're doing as naturopathic doctors. I had a doctor yesterday compliment me and say, your approach is so integrative and holistic. And I'm like, dude, this is just good old naturopathic medicine. I'm just using GLP-1s in addition. Like I already had this. This is what I've been doing for 20 some years,
We're getting cellular changes here. It takes time.
Yeah, right. And to add to that, for every year a patient has had a condition, it's going to take at least a month to even touch it. So this is a slow process. And you make such a good point with toxicity. Weight loss needs to be slow and low too. So not just the dose, but we're not, a pound a week is my comfort zone. Beyond that, I think people are going to, unless they're really, like you get a really fit individual who's just trying to do a cut really quick, but they've got excellent muscle mass, like that's an easy, drop 20 pounds. And I'm not too concerned about their health overall. But when you've got someone who's got a lot of weight or even a moderate amount and it's been on them a long time, that fat's got a whole lot going on inside that we want to process well. And
the issues are in the tissues. So they're there, they're waiting.
Totally.
Unleash the beasts.
Okay. Well, this has been so insightful, Dr. Lattanza. Tell everyone where to find you. I know that you specialize in cardiac health. So are you taking new patients for cardiac health at your clinic in Arizona?
Absolutely. Yes. So I am taking new patients. I am with Natural Heart Doctor in Scottsdale, Arizona. I see patients in person and really globally. So you can find me on Instagram at Dr. Lattanza and also at Natural Heart Doctor and on our naturalheartdoctor.com.
Okay. And just to clarify for the audience, people who are going to hear this and you're going to get bum rushed with people demanding you prescribe them GLP-1s. That's not really what you're doing there. So, I mean,
I'm not. And I've said I've dabbled. It's not my go-to. I will say I'm very much a root cause physician. That is the bottom line. So if it's not your problem and you're just coming to me with excellent lab values and it's just for vanity's sake, that's probably not going to be my go-to. But it's worth a discussion, but always test and not guess. So I always lead with labs and a clinical discussion.
Yes. It's cardiovascular based. In fact, I need to actually have you run labs on me. I was thinking about you the other day. I was like, I'm 50. I probably should.
I got to look at some of those cardiac specific markers. It's always good to check under the hood and
a little
make sure we're not
look-see.
missing something. Yes.
Yeah. Okay. Well, I just love you, lady. You're a wealth of information and knowledge, and you're always so kind and generous with it. So thank you so much for coming on the show today. I'll make sure all your links are in the show notes for people to find you. Follow her on Instagram, guys. Follow Natural Heart Doctor too. It's great information. And I will leave you with that. Thanks, lady.
Thank you so much. I'm so glad you called.
All right. Thanks for listening to the Dr. Tina Show. This is a Wellness Loud production produced by Drake Peterson and mixed by Mike Fry. Theme song is by John the Guilt. You can watch the full video version of this podcast inside the Spotify app or on YouTube. As always, you can email the podcast at podcast@drtina.com. That's DRTYNA. And if you like this episode, please rate, review, and subscribe on your favorite podcast app. You can also find all of my offerings on my website at drtina.com. For more shows by my team, go to wellnessloud.com. See you next time, and thanks for listening. This podcast is for general informational purposes only. It does not constitute the practices of medicine, nursing, or other professional healthcare services, including the giving of medical advice. I am a doctor, but I am not your doctor. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is intended not to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.